Hello, Vincent Carroll speaking. This is tutorial number 45. Do 26. Do 26 is a wonderful point, and I've used it quite recently on a number of occasions, and I just want to share my experiences of it with you. First of all, where is it located? It's located between the upper 1/3 and the lower 2/3 of the philtrum. The philtrum is that part of the anatomy, just below the septum of the nose and the upper lip. So it's midline, obviously, because it's due channel. And I often use it where a person might have acute mid-back lower pain, particularly lower pain, but it can be a bit higher in the thoracic area as well. The classic example is where somebody might have stooped down to have picked up a heavy object beyond their capacity perhaps, and they develop an acute pain midline, and that acute pain may radiate marginally to the right or the left, but the patient will tell you very plainly that it originated midline. In other words, it's a due channel injury, or to use the language of acupuncture, to put acupuncture English on it, we would say there's a chi and blood stagnation in the due channel midline, and that midline may be anything. It might correspond, for example, to the Ming Men if it were at maybe L2, L3. That's the Ming Men 0.24, or it could be 0.23, or it could be higher up, or it could be lower down in the sacral area. But one way or the other, it's midline, and it's over the distribution of the due channel. And it tends to be sudden, abrupt, and the patient will tell you without hesitation that it is midline as opposed to one side or the other. Now, with the passage of time, and that can be several hours, the pain may radiate one side or the other, and it might start to affect the urinary bladder channels, which of course are 1.5 swung right side, left side, or even out further into the outer back shoe points of the urinary bladder channel, which are 3 swung lateral to the due channel, which of course is midline. But there's always a beginning, and the beginning is midline, due channel, and there's absolutely no doubt about it. And it's usually where a person is bending down in a kind of a straight way, bending down to pick up something rather than swinging themselves to the right or the left. If you do that, you're more likely to affect the urinary bladder channel. But as for the due channel, it's remarkable in that the history taking will be very, very precise. What the patient will tell you, they will tell you that it's midline, that it was sudden, and that it was abrupt, and that it was connected with a particular act that they were doing. Now, normally if a channel has chi and blood stagnation on it, what do? Well, you drag it down as far down as you possibly can. But the difficulty, of course, with the due channel is it ends in due 1, which sort of is down in the coccus area. So therefore, you can't really drag it down. And quite apart from chaperoning and medical legal issues, I mean, the distance itself isn't very far. So therefore, you're not going to get a sufficient drag or a pull on the channel to achieve any sort of an effective result. So you drag it the other way. So you drag it up over the head, top of the head, remember, is due 20, right down past the forehead, down to the philtrum, point due 22. And what I find point due 26, and what I find is a very, very effective form of treatment is for the person who'll probably be extremely restricted when they come in to see you, to get them to stand with their hands on a chair, and for you to needle them when they're standing, to pop in only one needle, do 26, and to manipulate it, that's to say to twist it, to plunge, to lift it. They won't like you for that, but it's very, very effective. It's incredibly dynamic. But when they're doing that, for them to start using their feet in a marching type movement, putting their feet up and down and moving and limbering up. And the whole purpose is to get them up to a level where they can lie on the couch on their tummy, and then you can needle locally. I've no hesitation needling into the due channel. I might also needle a little bit laterally into the urinary bladder channels, right side and left side. I'll apply moxa. I will cup. I make certain not to cup over the midline. I'll cup laterally along the urinary bladder channel and pull downwards and outwards. And of course, a moxa and a little bit of electro can be all very helpful. But you know, you would do that in a proportionate way, depending on the nature of the injury. I mean, if it's still a very, very midline pain, and if it doesn't radiate anywhere, I think moxa plus needling the DO channel gently would probably be an initial treatment and probably would be sufficient. I wouldn't necessarily needle in to the urinary bladder channel or indeed apply electro. It depends how it settles up. If you get it in time, and DO 26 in its own right as a standalone point sometimes can be sufficient. If you get the person on time, if the injury is sufficiently ring-fenced and acute, DO 26 will be the point that is all that is needed, because the needles will decompress to excess, if you like, and of course you've dragged it down as well, up and over and down to DO 26, and that might be enough. But if not, I mean, the patient may come into you many hours later. At this stage, there obviously is radiation of the pain, and it may radiate both right side and left side. I find it usually does, and that then makes it easy to say, well, look, if it radiates to the right and the left equally, it must have started in the middle. So it is a DO channel issue, and you probably have to needle and use electro on the right side and the left side. Never cross the electro over under any circumstances. I do the right side only, the left side only, and I would apply gentle electro, watching the needles, watching the muscles contract just within their design limits. I mean, all you want to do is get the muscles to rediscover their original normality, nothing else. Now, you might ask other questions as well with the passage of time. I mean, you might wonder, was it proportionate that the muscles failed, that there was this sort of injury to the person's back compared to what we're doing? And if they were lifting something sort of in a pub, for example, or a bar, a keg of beer or something like that, yes, you can well understand in circumstances like that that would be a very proportionate injury. But if the injury was unproportionate, and if it was lingering, and if there were many other injuries, you would have to ask, have the muscles failed below the design limits? And if they have, then perhaps there's a liver blood deficiency, lubricant liver blood deficiency, because the liver's invading the liver, and the liver's not able to redistribute, not able to distribute liver blood around the body as a lubricant, so muscles fail below the design limits. But that's another line of questioning, and I think I've covered that in another tutorial. But as for now, all I want to say is I find DO 26 a marvellous point if the injury is absolutely midline, and if you're fortunate enough to get the patient as rapidly as possible. It'll allow the patient to limber up sufficiently to lie on their tummy on the couch, so that you can then do a more thorough examination and put in appropriate needles to decompress the excess. Thank you very much.